But to follow on the question, you work part-time for the Royal Australian College of General Practitioners.
Correct.
And have some leadership over the academic post program. So can you tell me a little bit about that program, on what it is?
Yes. So maybe for your non-medical fans, we are both general practitioners, so family medicine physicians, and a subspecialty within that, or a special interest, is academic general practice. So we combine seeing patients clinically with interests in research or medical education, or both, or related fields like academic publishing, writing, journal work. So within the Royal Australian College of General Practitioners, we have a structured 12-month program for our trainees, so on their way to becoming specialist general practitioners. And as part of their training, they combine part-time clinical practice with a 12-month part-time academic post. And in the academic post, they have a university appointment at any university medical department in the country. And they undertake a small research project, usually in a topic that's very grounded clinically and has come from some moment of frustration in clinical practice or a clinical interest. And they teach medical students. And a lot of them who are interested in medical education will be involved with curriculum design, assessments, marking OSCEs. And so they get a taster of what life is like for you and me as GP academics.
And for some of the North Americans, the sort of academic general practice program in Australia would be like a family medicine residency. So fully qualified doctors trained to become specialist family physicians. And why is it important, from your perspective, that we invest in research and in junior researchers in family medicine, in general practice?
There are endless reasons to this. So if we break it down into why do you need to invest early, and why do we need to invest in trainees when they're still undergoing their vocational training, it's because if we can inspire and expose them to academic careers, they will see this as a long-term career option that otherwise they may not get an opportunity to. And so that's the point of the program, is to give a taster of what life is like. We need to have research done for GPs, by GPs. How we get inspired for research so often is because of some clinical problem that we've seen in general practice, or we have checked guidelines and they don't match with what we're seeing in clinical practice, or there is some conundrum that we're trying to solve, some way we're trying to treat a patient and we don't know how the best way is. So then we need to find out, what is the best way? How do we provide the best, safest care? All of that comes from research. You need to do really investigative work. That's what research is, right? To answer a problem so that you can solve the problem and translate that into better patient care, which is what our job is.
And the way sometimes I think people can lose a little bit of sight of the words between research and science, but this is part of the scientific method. Observation of some interesting phenomenon. So for us as doctors, as clinicians, that might be problems and issues we see in our delivery of care with patients. And sometimes some of those issues and questions are not answered, and they become the best research questions because they directly potentially benefit the people we're actually providing care to, if we're able to find an answer.
And if we can't find an answer, that's helpful too, because it means that we don't have that kind of convincing body of evidence. And so then we contribute to showing either way we're seeing equivocal results.
One of the things that I'm interested in also is that there's a sort of inverse pyramid almost of scientific evidence. That almost all medical care is provided in the community by primary care teams, including family doctors, RACGPs, family physicians. And yet the evidence generation is often in hospital systems.
Yes.
Now, hospitals are very important, but
Yes.
for the most part, they're very rare events in people's lives.
Yes.
And what we know is that human body, biology, healthcare is actually very complicated, and evidence generated in a particular context, like a hospital context, not uncommonly can't be transferred into community practice, at least not without some major adaptation. It's not as simple as, it works here, thus it definitely will work in the community. Often it doesn't work in a community.
Well, often, Michael, when they test these things in hospitals, let's say the effectiveness of a drug in a hospital, those trials are so tightly controlled. They will accept certain ages, certain conditions, certain parameters to try and minimize any extraneous variables, to try and get the most data on does this drug work or not.
Yes.
The truth is that's not necessarily how real life is. That's not how our patients are. Whether a drug works or not is dependent on so many things, including the very basic, are they taking the drug?
Yes, yes.
If it's an effective drug in the human body, but it's not getting into a human body, it's not effective.
Yeah.
So the translation you're talking about in how we practice and the majority of healthcare in primary care is dependent on affordability of treatment, access of treatment, housing, finances, health literacy, every single phenotype that varies, every age that varies, the sex that varies, ethnicities of our bodies. Drug effectiveness is going to vary across all of that. So the very simple, does this drug work, is one question when it's tested in the hospitals. And endless. N equals endless.
Yes.
When we test it.
Yeah.
Yeah.
And that's even for what is often a relatively simple intervention like a drug.
Yeah.
It is, a matter of taking it and taking it at the right frequency.
Yes.
You sort of expect at least the biology should mostly be the same.
Yep.
Understanding people are different.
Yep.
But a lot of health interventions are not simple, like a drug. They're actually complex. Let's say we want to trial a program of care,
Yes.
Or some sort of intervention where different healthcare providers provide some degree of doctor or clinician-patient interaction that can do something, plus access to maybe learning type materials. Those sort of interventions, what might work in hospital outpatients, someone right after a very, very severe health episode compared to long-term preventive type of health in a community where people's motivations may be very different. In fact, there's no reason to believe that evidence in one setting will transfer to another setting.
Yeah, that's right. So when I was studying my own PhD, it was around supporting GPs for evidence-based pain management for long-term pain conditions that weren't related to cancer or end-of-life care, and how we can make sure we're prescribing meds like opioids, like morphine, in the safest, most effective ways. And a lot of the time I was studying programs for low back pain, or these chronic musculoskeletal conditions that you and I see all the time. And you might know about the GLAD program, which is a fabulous physiotherapy and education program that people use to manage hip and knee osteoarthritis. But one of the biggest barriers to people accessing those kinds of programs was they didn't have the money for it. They're really expensive programs, and often our public healthcare system doesn't have the kind of funding to support a full engagement. So that intervention, which is, you would argue it is a complex intervention, even though it sounds relatively simple, is not necessarily going to work in the settings that you and I have because of all of these other factors. So how do we improve patient care when that gets in the way? That's when we start talking about things like, well, people are turning to pain meds because that is cheaper, that is easier, and that's maybe more accessible than the physio programs.
Now, yesterday we had a really interesting session that you and your colleague facilitated, where this year's academic post registrars presented their projects in a 3MT, so a 3-minute thesis type event. realised yesterday I shouldn't have asked you to pick favourites on which one you like
You
the
did
most.
ask me to pick a favorite.
But there was one project you found had an alignment to your own personal research.
Yeah.
And can you talk a little bit about that project? Just as a bit of a taste of the sort of projects that
Yeah,
registrars do.
definitely. Registrars watching, I did not pick a favorite. I got nearly tricked into this. I was explaining that a lot of our registrars, they have very clinically focused projects. And so they study things like endometriosis management, intimate partner violence, miscarriage, things that we see day in, day out in general practice. And we do have a registrar this year who I was delighted to see is studying opioid prescribing practices of Australian GPs. And when she joined as an academic post right at the start, I was really delighted to know that she knew some of my work. And it's always nice to get a registrar who has a similar research interest. This was not a favorite thing.
I was just remembering that project. So she did an observational study, effectively, looking at temporal trends to opiate prescribing in Australia. And there was a very interesting question because I lived through that period when in Australia codeine was up scheduled. So you used to be able to get reasonably large doses of codeine just over the counter at a pharmacy, and now they all need prescriptions. And there was the fear that there was going to be the transfer of over-the-counter codeine to harder, more intense opiates prescribed system. And very interestingly, that observation was not seen, which I think was probably contrary to expectation, actually.
I think that's true. So there was a period of time, kind of really 2017 to 2020, when there was a whole suite of prescriber, systems level, patient level interventions happening to try and reduce inappropriate opioid prescribing. What was really interesting is I started my PhD in 2018 studying this right at the heart of seeing actual live changes from massive policy efforts. So one of them was also the nudge letters. So a whole, the top number of opioid prescribers in Australian general practice, so GPs, were sent a letter signed by the chief medical officer or the chief health officer saying you are a top prescriber of opioids. And we call this a nudge technique, and it's a very effective behavior change technique, particularly for doctors, because we know from understanding behavioral practices of doctors, particularly around problematic prescribing. So opioids, benzodiazepines, that generally doctors want to be in the middle. They don't really like knowing that they're on extremes and that they're not practicing the way their peers practice. This has been well established in different areas. So the nudge letters work because you're pointing out that a doctor is outside of the norm. So it does work to reduce those behaviors, but it feels very punitive, and it caused a lot of negative feedback, negative feelings, which I actually covered because I interviewed a lot of doctors who had received these letters, and they were saying, well, I see a lot of older people, I do a lot of palliative care, I have a special interest in chronic pain management, that's why I'm a high prescriber. I don't want another one of these letters, so I guess I'm not going to see this anymore.
So it's not to, I suppose, derail this conversation, but certainly there is potentially greater policy implications that perhaps the behavioural economics approach is ignored somewhat. I agree. I think very, very effective at that behaviour change. But the potential professional relationship that prescribers, clinicians have, the social licence with government and with regulation, I think that was quite damaged by those. So
we can also link it back by showing that a lot of the research that we do and the work that we do is not a single arm just looking at one. We consider so many things, which is impact to patients, impact to prescribers and doctors like us, but also impact to policymakers. All of the that's why we do qualitative and quantitative research, because we capture a massive impact of medical research.
Yep. Now, where to next for the academic post program? So, I think this year was it this year was the first year it came back to the Royal Australian College of General
Correct.
Practitioners. Previously, it was run by really the Department of Health. There was some good news that was certainly emphasised in the conference, but I think it might have been released prior to the conference. That
Yes.
well, tell us about the good news.
Fabulous news. It's really wonderful news. So we have generally had a cohort of up to 20 academic registrars per year. And in 2026, we are actually going to have 27 registrars. We had 18 registrars this year. So we've got a 50% increase in our cohort size, which is so exciting for the program. So great to see the interest and the increased funding for what I think is a phenomenal program.
Yeah, and so I think 27, 50% uplift, certainly excellent. In the context, however, there's probably around about 2,000 in sort of round numbers, registrars, so family medicine trainees entering the program every year. So it's actually still quite a small percentage of the total cohort. And my understanding is that the program has actually been quite competitive insofar that people
Correct.
wanted to join the program but not having a place.
Correct.
Like, blue sky thinking, how many positions do you think would be really able to increase the capacity of primary care research in this country?
Also, given that we've got a big bulk of GPs who are going to be retiring, and so we need to be mindful of filling that gap in the workforce, which will also extend to the research community. I agree. 27 is still small in the grand scheme of things. It is a win that we have had this expansion, but would we like to see the program expanded more? I'm sure everyone will say yes. What we saw at the showcase yesterday was really phenomenal support for the program and for the registrars, and it's inspiring academic careers. So the program's working. The funding comes from I think hopefully us continuing to demonstrate that there is a need and effectiveness of the program, and we would love to, I think, continue to expand it for sure. The other thing I'm very mindful of is that it is a competitive program. It's designed to be a competitive program. So I think at some point it's always going to stay as a competitive program. But we have demonstrated interest. People are applying, registrars are applying for this program. Not everyone is being selected. So that cohort of people who don't get in is probably the cohort you're talking about how we can include them. Because if they don't get an academic post, does it then demotivate them to continue in an academic pathway? So we're losing these registrars. Or do they continue in an academic pathway anyway? In which case we really should be capturing these registrars. So I think we're just going to keep working on this, Michael. I don't have a quick answer for you. Would I like to see it expanded? Yes. The more funding you give, we probably will keep expanding it.
These simple numbers, simple slogans. I think I mentioned yesterday, 100 registrars in 5 years. I think that sounds pretty good.
It will change the way we deliver the program completely, and it will really expand it, and probably that will be a good challenge for me in this role, a great career goal. But I think if you keep giving us funding for registrars, we will say yes.
And everything costs money, obviously, but in a grand scheme of things, when you look at the total size of the federal budget or even the health budget, it's chump change. It's rounding errors of changes in inflation, basically. So I think it's really important to have this capacity building element to the program. You might be familiar with the paper, I think it was in Annals of Internal Medicine, maybe, Bodenheimer's paper on the 10 building blocks of high-performing primary care. Right at the bottom is engaged leadership. And you really need programs to build that leadership for young and upcoming trainees, I think.
And I'm actually grateful because this whole question is also you demonstrating that there is effectiveness in this program and value in this program. which we saw again yesterday. So I think the more advocacy we get from, senior leaders in the Australian general practice community saying this is a good program, keep funding it, keep expanding it, we will.
Thank you very much for the game and the interview. Yesterday you felt a little bit enthusiastic that you might play a little bit more chess. I'm not sure what your thoughts are after today's game.
No, it's the same. I loved it. Clearly, as you can see, I could do with a little practice and not maybe make illegal moves.
It's just meant to be fun. So.
I had fun. I always have fun. Yeah.
Thank you very much, and I'm sure we'll catch up again at a future conference.
I really look forward to it, and thank you for the support of the Academic Post program.
Yeah, no worries.
Yeah.
All good.
Thanks, Michael.
See you later.